Well, good morning, good afternoon, and good evening, everyone. Welcome to today's RettSyndrome.org RettEd webcast. This is Paige Nuez, Director of Family Empowerment at RettSyndrome.org, and also proud mom to Katie, our beautiful 15-year-old who has Rett syndrome. On behalf of our board of directors and team, we're so pleased to bring you today's presentation. Your children are so important to us, and we believe in supporting you every day on our shared journey while we simultaneously and aggressively pursue research towards real treatments, interventions, and ultimately a cure for Rett syndrome. We invite you to visit RettSyndrome.org for information regarding all of our research and family empowerment programs, and especially visit the RettEd page at RettSyndrome.org/RettEd to see our calendar of upcoming webinars. Registration is open for all of them, and you can also find links to prior RettEd webcasts and conference presentations. Before we begin today's presentation, I'd like to share some brief technical points on how GoToWebinar operates in case this is your first time joining us. The audio feed is open only for our presenters, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you'll see a control panel window for the GoToWebinar app. We invite you to type your questions or comments in the question field throughout the presentation, and we will answer these at the end of the slideshow, as well as answering any questions that were pre-submitted during your registration process. If we don't get to your question today, we will work with our presenter to get all write-in questions answered and posted in a QA document to our RettEd webpage once completed. If the control panel is distracting to you, you can minimize or move the window. Then you may expand it at any time if you wish to submit a question. Next point is a reminder that the session is being recorded. We will post a link of the recording along with the QA document to the RettEd webpage so you can listen again, or please share with others who are on your child's care team that might benefit from this information. If you're having trouble hearing, please check and turn up the volume on your phone or device. Okay, now I'd like to introduce Dr. Kathleen Motil, pediatric gastroenterologist at Texas Children's Hospital and research scientist at the USDA ARS Children's Nutrition Research Center, Baylor College of Medicine. She is a member of the American Academy of Pediatrics, American Society for Clinical Nutrition, and past chair of the Ethics Committee for the North American Society for Pediatric Gastroenterology, Hepatology, Nutrition, where she received their Distinguished Service Award in 2015. Dr. Motil has been a longtime PI with an NIH natural history study of Rett syndrome. She's been involved in Rett syndrome clinical research and clinical trials and has spoken at countless conferences and workshops on Rett syndrome worldwide. And she's a really respected advisor and friend to all of us at RettSyndrome.org and throughout our community. In fact, I'd say one of her primary research interests and direct impact in our community over the course of her career has been to study and guide clinical practice around nutritional interventions that improve growth and body composition, such as bone health and Rett syndrome. She's going to talk about some of these things today. As one parent commented to us recently, Dr. Motil has saved our daughter at so many levels, and we couldn't agree with this statement more. So with this introduction, we welcome you, Dr. Motil. If you're ready, I will turn the screen over to you now, and you may begin your presentation. Are you there with?
Wait 1 second.
Sure. Oh, good. We can hear you just fine. And there we go. I can see your slides.
Okay. Well, thank you, Paige, and good afternoon and good morning to everyone out there. My old friends and I guess my new acquaintances. The topic for this afternoon is common GI issues in Rett syndrome, how to intervene, and some clinical research outcomes that we have. So I like to begin with comments that I hear. Parents frequently have a number of concerns about their daughters who have Rett syndrome, and the ones that I hear most often are the following. My daughter eats all of the time, but she doesn't gain weight. My daughter screams constantly. I know something is wrong. My daughter's stomach is full of air. It must hurt. My daughter won't go to the bathroom unless I give her something. I don't want her to become addicted. So the point I want to make about these concerns is that they are not necessarily a Rett thing. Rather, the striking feature about all of these concerns is that they really may relate to motility disturbances of the gastrointestinal tract. So my objectives for this presentation are fourfold. By the end of this hour, I hope that each of you will be able to recognize problems related to GI dysmotility in Rett syndrome. I hope that you will be able to recognize the trigger signs to call your physician. I hope that you understand the rationale for ordering GI tests. And I want you to understand the approaches that we use to treat GI dysmotility in Rett syndrome. This slide summarizes the types of gastrointestinal problems that we see in Rett syndrome and the frequency with which we see them. Approximately 5 years ago, we conducted a survey with the help of Rett Syndrome Organization. Nearly 1,000 families responded to our questionnaire about gastrointestinal problems. 92% of all of our families who responded felt that their daughters had some sort of problem with their gastrointestinal tract. Chewing and swallowing dysfunction was present in 56% and 43%. Feeding difficulty was present in 81%. Gastroesophageal reflux was present in 38%. Biliary tract disease was present in 4%. Gas bloating was present in 51%. Constipation was present in 80% of their daughters. The point of this slide is that every part of the gastrointestinal tract can be affected with poor motility. And most individuals with Rett syndrome actually have problems related to gastrointestinal dysmotility. I want to focus especially now on the evaluation of these gastrointestinal problems in our girls. The first is chewing and swallowing dysfunction. Although parents tell me that their daughters have a good appetite, feeding difficulties occur in 80% of our girls with Rett syndrome. Feeding problems occur because of the neuromuscular abnormalities associated with chewing and swallowing. Chewing difficulty is defined as poor mastication or the ability to bite into food in a coordinated fashion. Poor tongue lateralization is the ability to move food to the side, from one side of the mouth to the other. And poor food propulsion is the ability to move food forward from the front to the back of the mouth. Swallowing difficulty is defined as pulling of liquids and solids in sinuses adjacent to the separation of the breathing tube from the feeding tube. Penetration of liquids into the larynx refers to the beginning portion of the breathing tube where things get stuck. And aspiration of liquids into the tracheal breathing tube is the more serious endpoint from this abnormality. The X-ray on this slide is actually taken from a swallow function study. If you follow the white line of barium from the mouth into the throat, you can see the line of barium as it penetrates into the larynx, the beginning portion of the breathing tube. The importance of this finding is that chewing and swallowing dysfunction places the child at risk for aspiration. Now the question is, why do we want to treat chewing and swallowing problems? We always want to treat to control symptoms and to prevent complications. Girls with Rett syndrome who have difficulty eating because of the chewing and swallowing difficulty get hungry and they get irritable. Conversely, girls with Rett syndrome who have difficulty eating because of chewing and swallowing difficulty get feeding fatigue or feeding refusal. As a result, their feeding efficiency is decreased. complications of chewing and swallowing difficulties are progressive malnutrition from inadequate dietary intake and aspiration pneumonia from incoordination of the neuromuscular function. When parents have concerns about chewing and swallowing problems, I listen for 4 specific issues. Children who take longer than 30 minutes to complete a meal have reduced feeding efficiency. Children who repeatedly cough, choke, or gag with liquids or soft foods have difficulty initiating a swallow. Children who refuse to eat or turn their heads away have feeding fatigue. The effort to eat is more work than they can accomplish. Children who have weight loss or poor weight gain are unable to meet their nutrient needs for normal growth. In this setting, the most problematic period is in fact the adolescent growth spurt. Body fat stores disappear and linear growth arrest may occur. Increased activity from the repetitive hand movements, such as hand clapping, does not contribute to weight loss or poor weight gain. And we know that intestinal malabsorption does not contribute to weight loss or poor weight gain. There are 2 diagnostic tests that we use to help assess chewing and swallowing difficulties. The swallow function study, which was shown in the previous slide, is a radiographic study performed with the assistance of a speech pathologist. Chewing and swallowing skills are assessed using thin and thick liquids, soft or pureed foods, and a crunchy cookie. Girls with Rett syndrome typically perform best with thick liquids and soft or pureed foods. The body mass index is the gold standard for assessing the nutritional status of an individual. The body mass index is a measure of proportionality between body weight and height. The graph shown on this slide is used to plot and compare the body mass index of girls with Rett syndrome against the body mass index of unaffected girls. For girls with Rett syndrome, a healthy body mass index ranges between the 25th and 75th percentile. A body mass index less than the 5th percentile or below the bottom line of this graph is a red flag and should prompt further evaluation and intervention. The treatment approach to chewing and swallowing difficulties is limited. We recommend occupational therapy or speech therapy for the assessment and treatment of oral motor function. Oral motor skills tend to wane with advancing age. If oral motor skills are not used, they are lost. VitalStim is an electrode device that is applied to the neck in an effort to stimulate muscles associated with swallowing. This device is used primarily in adult stroke victims with reportedly favorable outcomes. At the present time, however, we do not have data to support or refute the use of this device in children with neurological disabilities, including Rett syndrome. The treatment approach to feeding refusal is the use of alternative feeding methods. In some instances, weight gain can be achieved with the use of oral formula supplements as the primary source of nutrition. When oral feeding is unsuccessful, a nasogastric feeding tube or a gastrostomy button becomes necessary. A nasogastric tube, which is a tube passed through the nose into the stomach, may be used to support weight gain for short periods of time. Gastrostomy or gastrojejunostomy tubes require surgical or radiological placement. These modalities are used for long-term treatment of feeding refusal. The indications for the use of alternative feeding methods are threefold. The first is a body mass index less than the 5th percentile or a progressive decline in body mass index below the 5th percentile for more than 6 months. The second is significant chewing and swallowing dysfunction that leads to repeated aspiration pneumonia. And the third is actually my parents who request a button placement, particularly in the setting of persistent feeding refusal or difficulty with medication and fluid administration. The next problem is gastroesophageal reflux. Gastroesophageal reflux is defined as the involuntary passage of stomach content backwards into the esophagus and mouth. Stomach content includes acid, digestive enzymes, and bile, all of which can injure or inflame the lining of the esophagus. Gastroesophageal reflux is caused by poor motility of the esophagus, the lower esophageal sphincter, or the stomach. Dietary, genetic, structural, hormonal, infectious, neurological, or environmental factors can affect esophageal and gastric motility. So again, the question is, why do we treat gastroesophageal reflux? Basically to control symptoms and to prevent complications. Gastroesophageal reflux feels uncomfortable, it tastes bad, and it interferes with eating and breathing. Untreated gastroesophageal reflux may result in esophagitis, which is inflammation in the esophagus. It may result in ulcers, a stricture or narrowing of the esophagus. It may result in aspiration pneumonia or a Barrett's esophagus, which is a change in the lining of the esophagus that places a person at risk for cancer in later life. When parents have concerns about gastroesophageal reflux, I listen for symptoms such as persistent irritability or screaming for no apparent reason, nighttime awakening with irritability, vomiting, regurgitation, wet or dry burps, feeding refusal, wheezing, or aspiration. A number of diagnostic tests may be recommended to evaluate gastroesophageal reflux. Oftentimes, a thorough medical history is sufficient to diagnose gastroesophageal reflux. The Upper GI series is an X-ray study that allows us to evaluate the structure and, to a lesser extent, the motility of the gastrointestinal tract. This study is important because it provides assurances that the upper gastrointestinal tract is in the correct position and that no obstruction occurs. A pH probe study identifies the presence and duration of acid reflux, while esophageal manometry measures esophageal propulsion and lower esophageal pressures. An upper endoscopy with biopsies helps to identify inflammation if it is present in the esophagus. And the gastric emptying scan identifies delayed emptying of food from the stomach. The treatment approach for gastroesophageal reflux is threefold: dietary modification, positioning, and medications. Dietary considerations include the removal of spicy food, chocolate, caffeine, and citrus foods from the diet. Children with reflux should maintain an upright position for 30 minutes after eating, and the head of the bed can be elevated to about 45 degrees during sleep. Antacids and histamine receptor acid blocker medications tend to be less effective and are more cumbersome to administer for the treatment of reflux compared with proton pump inhibitors. Proton pump inhibitors comprise a better treatment choice for reflux and reducing acid production in children with neurological disorders who have gastroesophageal reflux. A surgical procedure, the fundoplication, may be recommended when other medications fail. Biliary tract disease, or more commonly gallbladder problems, represent three disorders: biliary dyskinesia, or gallbladder dysmotility, cholecystitis, or inflammation of the gallbladder, and cholelithiasis, or gallstones. We treat biliary tract disease to avoid complications such as hepatitis or inflammation of the liver, And we treat pancreatitis, which is inflammation of the pancreas, or the gland that helps with digestion. We now know that the prevalence of biliary tract disease in Rett syndrome is approximately 4%. This frequency is similar to the frequency of biliary tract disease in unaffected individuals. Biliary tract disease is found more commonly in our older girls, and a major risk factor is a positive family history. Although abdominal pain is the usual symptom, we always consider an evaluation for biliary tract disease in the presence of significant irritability or inconsolable screaming in our girls. The diagnostic tests used to evaluate biliary tract disease include an abdominal ultrasound and a HIDA radionuclide scan. Surgery is the treatment of choice for symptomatic cholecystitis and cholelithiasis. However, the treatment of biliary dyskinesia is a bit more controversial and is not as well defined. Gas bloating is defined as gastrointestinal air trapping. Gas bloating appears as abdominal distension that worsens as the day progresses, and the abdomen actually sounds like a timpani drum if you tap it. Gas bloating usually is caused by air swallowing in conjunction with hyperventilation, but it can result from malabsorption such as lactose intolerance or celiac disease. It can result from infections such as giardiasis, from small bowel bacterial overgrowth, or from poorly managed constipation. Why do we treat gas bloating? Again, to control symptoms and to prevent complications. Gas bloating may be associated with significant abdominal discomfort or pain, but it may also be painless. Burping or flatulence from air swallowing produces nitrogen gas, whereas burping or flatulence from carbohydrate beverages, sorbitol, or legume consumption can produce methane, carbon dioxide, or hydrogen gases. A rare complication of gas bloating is what we call pneumoperitoneum, which is defined as the presence of free air within the abdominal cavity. Pneumoperitoneum usually is caused by a perforation or a hole in the stomach or the intestines. When parents are concerned about gas bloating, I listen for complaints of poor appetite, hyperventilation with air swallowing, repetitive burping, abdominal distension, irritability or apparent abdominal pain, flatulence, or diarrhea. A number of diagnostic tests may be recommended to evaluate gas bloating. A medical history and physical exam, again, often is sufficient enough to diagnose gas bloating. A blood test may be ordered to evaluate the possibility of celiac disease, which is a dietary intolerance to grains. A stool sample may be tested for parasites that cause giardiasis, or the H. pylori bacteria that causes stomach inflammation and ulcers. An upper endoscopy with biopsies may be performed to confirm the diagnosis of celiac disease. A lactulose or lactose hydrogen breath test may be ordered to evaluate small bowel bacterial overgrowth or lactose intolerance. An abdominal X-ray, such as the one shown on this slide, can be obtained to demonstrate the extent of gas bloating. In this X-ray, the black areas in the bottom half of the slide represents significant intestinal distension filled with air. The treatment approach to gas bloating is limited and includes dietary modification and medications. Gas bloating can be reduced by decreasing the amount of carbohydrate beverages consumed, or by decreasing the consumption of sorbitol-containing beverages and foods such as prunes. The lactose content of dairy products can be modified by using a lactase enzyme product. A gluten-free diet must be initiated if celiac disease is found. Cymethicone is the primary medication used to reduce gas in the intestinal tract. Selected antibiotics, including metronidazole or clindamycin, may help to reduce small bowel bacterial overgrowth, but the results often are temporary, and the medications may actually be associated with unwanted side effects. The use of laxatives such as polyethylene glycol, milk of magnesia, mineral oil, or Senocides may be helpful to better control the problem of constipation. Constipation is defined as difficulty with defecation, causing discomfort, and lasting more than 2 weeks. Bowel movements usually are fewer than 2 times per week. Stools are hard, small pebbles, or large balls in size. The cause of constipation may be functional, such as inadequate dietary fiber, structural, such as tight anal openings, neuromuscular, such as Hirschsprung's disease or muscular dystrophy, endocrine, such as hypothyroidism, or drug-induced, such as the use of narcotics or even seizure medications. And again, why do we treat constipation? We want to avoid symptoms and prevent complications. Constipation may be associated with abdominal, rectal, or anal pain, poor appetite, diarrhea from overflowing continence, and bleeding. The complications of constipation include anal fissures, fecal impaction, encopresis or soiling, and a volvulus, which is an obstruction from twisting of the intestines. When parents are concerned about constipation, I listen for complaints of reduced frequency of bowel movements, fewer than 2 times per week, a change in the consistency of stool, either hard or watery, blood on the stool, abdominal distension, discomfort or pain, a lot of flatulence, urinary tract infections, feeding refusal, or vomiting. Diagnostic tests that may be performed include a thorough medical history and physical exam, including a rectal exam. An abdominal x-ray, such as the one shown on the left side of this slide, may be obtained to assess colonic stool burden. The haziness on the bottom of the x-ray, shown in this particular slide, shows a very large stool impaction in this child. A SITS marker study may help to assess colonic motility. A barium enema is an X-ray study that helps to assess the structure of the colon. Rectal manometry helps to assess the contraction and relaxation of the rectal muscles at the end of the colon. And a rectal biopsy helps to evaluate the presence or absence of nerve cells that assist with colonic motility. Finally, a colonoscopy with biopsies helps to evaluate the presence of other inflammatory types of disease. The treatment approach to constipation is threefold, including dietary modification, medications, and physical activity. Dietary fiber such as fruits, vegetables, and cereal is an important first step. Sorbitol, which is a non-absorbed sugar in prunes and to a lesser extent in pears, may be a helpful additive. Probiotics of choice also may help to establish good bowel habits. However, medications usually are necessary to maintain good bowel habits. Laxatives, both softeners and pushers, may be used alone or in combination. Examples of these types of medications include polyethylene glycol, lactulose, mineral oil, milk of magnesia, or Senocides. Newer chloride channel medications, such as lubiprostone or linaclotide, are available for individuals who are older than 18 years of age, and these drugs actually come with black box warnings. Suppositories such as glycerin or bisacodyl may be necessary as the girls get older. Enemas or surgically placed cecal buttons may be required if stools become impacted on a more frequent basis. Finally, be aware of herbal preparations. They may contain compounds that are contraindicated in the presence of the prolonged QT abnormality. And lastly, physical activity, whether walking, standing, or receiving physical therapy, helps to maintain good bowel habits. Finally, I want to highlight some gastrointestinal crises, which are more serious complications of gastrointestinal dysmotility. In this setting, we see individuals who are seriously ill, have significant abdominal pain and distension, may have bilious vomiting, and generally have a medical emergency that requires surgical intervention. The surgical problems include volvulus or twisting, intussusception or sliding, and perforation or having a hole in the stomach or the intestines. The cause of these gastrointestinal complications is not known, but probably is multifactorial. Air swallowing alone does not result in intestinal perforation. Chronic constipation or a dilated megacolon may increase the risk for intestinal obstruction. Volvulus, intussusception, and perforation can occur in unaffected children. They are not unique to Rett syndrome, but they do raise concern, particularly in the context of children with neurological disabilities, including our girls with Rett syndrome. The question is, why do we see gastrointestinal dysmotility in individuals with Rett syndrome? This slide summarizes the results of a study conducted by scientists at the University of Ottawa and the Children's Hospital of Eastern Ontario. Scientists examined the nerve network of the gastrointestinal tract, which we call the enteric nervous system, in human and mouse tissues. The scientists found that the protein product of the MECP2 gene was found throughout the gastrointestinal tract. It was found specifically in the ganglia of the enteric nervous system, and it was found throughout growth and development of the GI tract. The point of these observations is that gastrointestinal dysmotility in Rett syndrome may be caused directly by the abnormal MECP2 protein within the enteric nervous system, rather than indirectly from the abnormal protein in the central nervous system in the brain. These investigators also have demonstrated that neurotransmitter imbalances may account for gastrointestinal dysmotility in their mouse model. Intestinal transit time was 3 times longer in the MECP2 knockout mouse compared with wild mice. Nitric oxide, an important neurotransmitter, was decreased in the enteric nervous system of the MECP2 knockout mouse compared with the wild mouse. And nitric oxide did not respond to hyperkalemia, which is a nerve stimulant, in the MECP2 knockout mouse. These studies suggest that the abnormal MECP2 protein is associated with what we call the loss of neuronal plasticity, or the ability of the nerve to react and then readjust and restore basal and normal nerve function. The second area of research is the regulatory role of the gut microbiome in Rett syndrome. Animal studies suggest that changes in gut bacteria affect both the central nervous system and the enteric nervous system function. We suspect that alterations in the gut microbiome may in fact underlie some of the intestinal dysfunction of our girls with Rett syndrome. So we are conducting a study to characterize the features of the microbiome in our girls and in unaffected healthy girls. The graph on this side illustrates some preliminary results that we have, and in fact show you the differences in the bacterial colonization of the girls and women with Rett syndrome and the unaffected girls that we have studied. The different colored bars represent the different groups of bacteria throughout the gastrointestinal tract, and the size of the bars represent the relative abundance of each of these large groups of bacteria in the gut. It is very clear to us that the gastrointestinal microbiome of girls with Rett syndrome differs from the microbiome of the unaffected girls. We also find that these differences in the microbiome can be explained in part by differences in age, differences in gastrointestinal symptoms, drugs, and the diet. So future studies will continue to explore the role of the enteric nervous system and the microbiome in Rett syndrome. We need to know more about the role of the MECP2 gene in the synaptic transmission and neurotransmitter synthesis and activity, with the goal of being able to detect differences in phenotype and genotype outcomes. We have partnered with the scientists at the University of Ottawa and CHIO to look at the enteric nervous system in our girls with Rett syndrome using intestinal biopsies that we have banked here at Baylor. We need to know more about the metabolic end products of bacteria with the goal of being able to better detect differences in the phenotype and the genotype outcomes, and have strategies for therapeutic interventions, particularly in gas bloating. In all of these projects, we hope that a better understanding about the role of the MECP2 gene in gastrointestinal function will lead to novel drug or dietary treatments that improve function and quality of life in our girls. And so, in summary, gastrointestinal problems commonly found in Rett syndrome include chewing and swallowing difficulties, feeding refusal, gastroesophageal reflux, delayed gastric emptying, gas bloating, and constipation. These problems are caused by dysmotility of the gastrointestinal tract, presumably because of the abnormal MECP2 protein within the enteric nervous system. Any symptom that causes parental concern should be evaluated by a physician, and selected diagnostic tests may be obtained. Treatment strategies should be discussed with your physician to improve symptoms, avoid complications, and to improve your daughter's quality of life. So thank you very much for listening, and I do believe it is time for questions.
Thank you, Dr. Motil. That was an excellent presentation, as always. Thank you so very much. We have had a number of questions come in throughout your presentation. I think some were submitted before you got to the answer already in your presentation. So we might be asking you to just kind of revisit some of these important topics that you addressed. So let's go ahead and get started. One of the early questions that came in is, my daughter is going through her third bout of pancreatitis in 5 months. Is this something that is seen in the girls as they get older? Her daughter is 19. And if so, what suggestions do you have to help get through these episodes and or prevent them?
Pancreatitis is not a common feature of Rett syndrome. Pancreatitis has many possibilities, or the cause of pancreatitis has many possibilities, ranging from the gamut of genetic factors to biliary tract disease and infections. So from my perspective, it would be extremely important, particularly with recurrent pancreas issues, to have your daughter be seen and evaluated by a gastroenterologist. And in the case of a 19-year-old, by that time we're often transitioning your daughters to some of our adult colleagues. Sometimes we have to help train your adult colleagues, but I think it would certainly be prudent to have a gastroenterologist involved in this sort of setting. The third point is that pancreatitis can be difficult to treat insofar as there are no magic medications to either prevent or make the inflammation of the pancreas go away. It's usually symptomatic support that can run the gamut of IV fluids, IV nutrition, pain medications, medications to help with the vomiting, and tincture of thyme. But again, I think a thorough evaluation and, if possible, a causal explanation for why recurrent pancreatitis is occurring is a very important component of this whole intervention program.
Okay, thank you. We have a couple of questions about reflux. Okay, so one of the questions is, can replacing oral feeding with a G-tube help with reflux?
There are studies in the very old literature that suggest NG tube feedings, or in some cases a gastrostomy button, can be used to treat reflux. However, in our girls, the issue is much more complex. The use of a tube, a nasogastric tube, is only a short-term fix, and so probably not one that I personally would choose. A gastrostomy button may help with feeding, particularly when the girls have significant vomiting, or in fact a gastrojejunostomy tube where you bypass the stomach entirely and pass the tube farther into the beginning portion of the small bowel, can also help to reduce the vomiting with reflux. The problem is that the girls may have significant dysmotility or backflow, and so no matter how you try to bypass the esophagus and the stomach, you may in fact still have reflux occurring. So if a button or a gastrostomy tube or a gastrojejunostomy tube is going to be entertained as a treatment, and if reflux is a significant problem, then in those settings, we would also think about a fundoplication at the same time. The fundoplication is a tummy tuck, and it is used as a type of a barrier to help minimize and reduce the occurrence of gastroesophageal reflux.
Okay, thank you. Is there, so with an NG tube, gastrostomy tube, or button, and the incidence of slow motility, can you find that sometimes just more frequent, smaller meals can help?
Absolutely.
With reflux before going to a fundoplication, and who would be the best person for a parent to work with to experiment with that?
Small, frequent feedings absolutely are very helpful. That's one of the standard, very early approaches. And in that setting, either your pediatrician may be a good resource, or your pediatrician may suggest a dietitian who is versed in working with children who have neurological disabilities and can help you find some good recipes or some approaches to types of foods that would be very nutritional and when administered in small, frequent feedings.
Okay, thank you. Trying to read through the questions here. Okay. Nighttime feedings. So someone had a question then, and I think that goes nicely with smaller, more frequent meals, and the possibility of being able to use the alternative feeding methods to get the goal hydration and nutrition by taking advantage of night times. Do you have any comments?
I do indeed, because I think nighttime feeding is a very valuable tool in the right setting. You can do nighttime feedings to provide a given proportion of the child's total daily requirements, nutrient requirements, and then leave the daytime for oral motor feeding. And from that perspective, you're really accomplishing two things. You're into the mode of use it so the girls don't lose it, and you're also into the mode of providing some pleasure feedings for the girls, because the girls do like to eat. And you're also in the mode of providing the rest of the calories, the nutrients, within the comfort zone of your daughters. The nighttime tube feedings is not always simple, however, if your daughters tend to move a lot, or particularly if their clocks are switched and they're up a lot at nighttime. So there are different strokes for different folks. But for those families who have daughters who do in fact have buttons, I like using the nighttime feedings when you have these multiple options and multiple goals that you wish to accomplish for your daughters. Paige? Hello?
Sorry about that. Sorry, I was on mute. Okay, so I'm going to stick with the theme of questions about the reflux and upper GI, and then we'll move on to the questions about lower GI. Okay, so our child has long QT. What reflux meds are okay for her? Are there... go ahead.
So the reflux, well, let me back up and say there are over 150 drugs that are contraindicated in the prolonged QT syndrome in general. I will parenthetically say that it depends on where you are on the spectrum of the prolonged QT abnormality. From the point of view of reflux, the major drug which was used in days past was cisapride, and that drug is no longer available on the American market unless you get it from across our borders. So cisapride should not be used in the prolonged QT abnormality. And the other class of drugs are what I call the mycin drugs. So erythromycin, for example, we will sometimes use that drug as a prokinetic or a motility drug. That drug belongs to the macrolide group of drugs. So drugs like erythromycin, clarithromycin, azithromycin, or the other one is trimethoprim sulfamethoxide combo. Those drugs preferably should not be used in the prolonged QT abnormality, and certainly erythromycin might be one that would be considered as a prokinetic drug for its motility activity in this situation of reflux. The other big class of drugs, I suppose, that children might get involved with the prolonged QT abnormality are the antifungal drugs. So things like clotrimazole, ketoconazole, itraconazole, those are a couple of other drugs that people should be aware of. And then the third group are the quinolones, which include things like ciprofloxacin, levofloxacin, the floxacin group of drugs. Those are also contraindicated in Rett syndrome, but these latter ones are not ones that we would use for reflux per se. All of your acid blockers otherwise, like your proton pump inhibitors, your histamine 2 receptor acid blockers, antacids are fine.
Thank you. And a quick reminder to everybody who's listening in, this is being recorded. When you receive the link to the recording, you can fast forward to get a chance to write down some of these drugs and the names if you were having a hard time keeping up with them. Another question is, when does the use of protein pump inhibitors become an issue? Do they become an issue after prolonged use? And if so, what are other alternative medications or procedures to help with reflux and frequent vomiting?
So the question of proton pump inhibitor use is one that I get asked often. The literature has a number of warnings, particularly in older folk like me who take proton pump inhibitors, because of their effect potentially on bone health and bone mineralization. That's one issue. The second issue is the thought is that the reduction of acid in the stomach with the use of proton pump inhibitors permits more frequent infections because you now reduce one of the barriers of the gastrointestinal tract. With respect to the first comment about bone health, the studies are thought in part to have some flaws, and not everyone agrees that bone health may be compromised. That's number one. Number two, not everyone agrees that you really do permit more frequent infections by blocking acid. My comment is that when you have a child who has a neurological disability with a number of issues, medication usage becomes a balance. The question is, what do you want to accomplish with the use of medications? From my perspective, I want to be sure my girls are comfortable and that they have a good quality of life. And in many situations, medication usage, including acid blockers of some sort, become necessary. I happen to prefer the proton pump inhibitors because I don't think the other drugs are as effective. They need to be given much more frequently. And many times, once I've got the acid reflux under control from a medication point of view, I can reduce the dosage of medication over a longer term period if we're going to use the drug. Now, we know from our natural history study that reflux is usually more of a problem in our younger girls. It is true, I do have some girls quite much older, who absolutely require some sort of acid blocker medication because otherwise they have very significant respiratory complications. So the use of drugs really becomes a balance. As always, we try to reduce dosages of medications when things are under control. And certainly, I will do drug holidays and see if I can get away without the medication, either for short periods of time, for a longer period of time, or maybe indefinitely as my girls age.
Okay, that's wonderful. Thank you. And I think we have a lot of questions here about long-term use with PPIs, with constipation medicines, with Miralax, especially in milk of magnesia, seeming to go in and out of effectiveness over time. And I have a series of questions here from our parents whose children have moved from pediatric care to adult care, who feel that the adult GI doctors may not be as informed about Rett syndrome, and they don't feel like they're getting as much support in how to maybe go on drug holidays or titrate or do cocktails of different medications. Can you talk a little bit about adult care and how to help? There's mixed in there some questions about difference in tone as the girls get older and become tighter, maybe having more troubles with constipation than they did earlier, but a lot of, how to help guide and inform the adult GI doctors that the girls are now seeing.
I'm going to start with the easier part of the question.
Okay.
And that is,
all right, there's a lot in there.
I see two issues here. One is the issue of constipation, which does indeed become more problematic as the girls get older. For me, I see this as a step-up type scenario. It is not uncommon as the girls get older for me to use multiple drug therapies. And again, this goes back to what I just said about a balance of medications. Constipation is one of my bigger issues, and it is really one of the areas where medication usage is really a must as the girls continue to age. Not only are medications a must, but often multiple medications, including combinations of my pushers and combinations of my softener medications. When medications by the oral route are not sufficient to keep the girls moving daily or every other day at a minimum and soft stool, then I will work with the bottom end with either suppositories, whether it's glycerin or moving toward bisacodyl. And if I have to, I will use enemas, and in some instances, we actually have put in cecal buttons, or in some instances, when the colon becomes so floppy and so not useful, in so many words, we actually have resorted to surgery in a small handful of kids to remove the colon. And in these settings, sometimes a permanent ileostomy is necessary. Sometimes a colostomy is necessary. So again, it depends on the individual child and the difficulties that one is having in trying to keep bowel health healthy. Now, the bigger problem is the transition to our adult care physicians. We know that your ability to find an educated adult clinician can be very difficult. They are a rare bird out there, but we know they exist. I've spoken with some of them, and some of them can be extraordinarily good. So finding a good physician, whether it's your general physician or a gastroenterologist, is well worth their weight in gold. I don't know of a good way to educate the adult folks on a large-scale basis. I suppose, Paige, we ought to have a selected webinar for adult physicians in the adult GI community. That would be a start. But the other point is that all of my parents, all of you out there, really do need to be advocates for your daughters and don't take no for an answer. We as physicians just sort of want to crawl under the desk when parents go at us and tell us exactly what they want done. But we know, really, that you're the best advocate for your daughter. And so if push comes to shove, we in the Rett community are always happy to take calls from your clinicians when they don't understand Rett 101, Rett 102, Rett 103, and now Rett 104. So I'm always happy to take calls from physicians around the country. I even take emails from physicians around the world. And so the way to spread the word really is going to be by word of mouth until enough of our girls transition and you begin the same sorts of efforts in the adult community that you've made in the pediatric community. And one by one, we'll all get there. So that's all I have to say about the adult folks.
Thank you. Yeah, we have a lot of work to do in this arena, both in this specialty and in other specialties. So I will welcome having you be part of an advisory council to start addressing this very important issue. Okay, so before we started transitioning from reflux, feeding, chewing and swallowing issues to constipation, let me finish up with the upper end before we move into the bottom end, if you would. For chewing and swallowing difficulties, Dr. Motil, who do you recommend that families work with? So question such as we have a family with a son with MECP2 duplication who ruminates with his tongue. So he can manage food, he gets his fluids and medications through a G-tube, but enjoys eating. But parent really wants to know who should they work with to invest more time in trying to get him to develop a productive, safe chewing and swallowing. They're already experimenting with pureed foods.
So there are one of two choices, but you need to know who does this in your local communities. Sometimes the occupational therapists will have developed their feeding program. Sometimes it is the speech pathologists who have developed their feeding program. So you need to ask your local physicians who in your local area best does feeding therapy with children who have disabilities. This particular area can be problematic because it is a very specialized part of the overall work descriptions, job descriptions of people in the occupational therapy or speech therapy field. So again, you must ask which specialty has the best people for feeding therapy. Oftentimes, you have to resort to your local medical centers for that initial evaluation and therapy intervention. And then you can take what you have been trained by people in the medical centers. You can take those educational programs to your local folks if you don't have anybody in the local area, or again, they can set up a communication channel to help accomplish the tasks that need to be done. But once again, this is another area of highly specialized people, and so you have to go to task asking the question, who in the community has training in feeding therapy, specifically with oral motor skills?
Okay, good answer. So, I think a lot of OTs and SLPs can identify the mechanics of what's going wrong, but really to get someone who's well practiced and well versed on changing those behaviors, you're suggesting just keep keep asking questions in the community to find that person who can go to the next level? And do you find that it's worthwhile and can be successful in our kids?
Oh, absolutely. Again, if you don't use it, you lose it, number one. And I should parenthetically add, too, for those of you who struggle with feeding your daughter and who are on a fence about the gastrostomy button placement, I think over and over again what we have seen is that when your girls have a baseline healthy nutritional status and are well fed, their feeding ability actually improves because they now have the energy to be able to do the work. And oftentimes we see ourselves reducing the amount of formula that is used because the girls have picked up in their efficiency of eating. So once again, if you don't use it, you can lose it. For some of the girls, it is a struggle no matter what. But if nothing ventured, nothing gained.
Okay, so thank you for that. I have another question, and then we're going to move to the lower GI questions. And a question seizure related, and actually this is a good bridge. So do you find that in your experience reflux can affect seizures and vice versa? And then I'll ask you the second part, constipation as relates to seizures. Do you think there's a relationship between reflux and seizures, and do you think there's a relationship between constipation and seizures?
Many of my families tell me there is indeed a relationship, especially with constipation aggravating seizures. I think any time you change the stability of your daughter, you run the risk of upsetting a lot of things. Anything that causes stress, we know aggravates kids getting sick, can aggravate seizures. And so the whole point here, and the whole point of, again, trying to fine-tune your daughter's health and well-being is really meant to improve your daughter's quality of life and for sure to minimize complications, including seizures.
Mm-hmm. Okay, let's move on to some of the lower GI questions. We're at 10 minutes after the hour, so we can spend about 20 more minutes together, and I think we'll be able to get through the majority of questions that we have. A lot of questions about pushers. So I've got a number of parents. I just want you to underscore and highlight this one again. Parents who've had great success getting the consistency okay, but still poop's not coming out. Can you talk about pushers?
So my favorite two pushers are good old-fashioned milk of magnesia and the Senocides. Milk of magnesia is exactly that. It's magnesium. Magnesium is an irritant in the gastrointestinal tract, and we usually use that drug on a weight basis. Again, what you need to know is that nothing is cast in stone. When I use my pushers, I give my parents ranging shots of the dosage amount, lower and higher, that will probably have some effect. Sometimes I will combine milk of magnesia with Senocides, but they may be a little bit more difficult to use. The liquid Senocides used to be a bit difficult to find. It's a very old drug. The Senocides are a very old drug, but there for a while they got to be difficult to find, and they tend to be a bit more expensive, particularly in the liquid variety. If the girls can swallow pills, that's great. Then you can have them just swallow the pills. The Senocides also come as some of these chocolate chewy kind of cubes. So if you can cut them up in small enough pieces, or if your daughters will chew and swallow, you have that option as well as a pusher. These two drugs by and far are our best pushers to help the girls evacuate stool. When the oral route becomes ineffective, that's when I really move to the suppositories, which serve as a stimulant and help the girls to evacuate. Either simple glycerin, which is really just an irritant in the rectum, as opposed to something like bisacodyl, which in fact is a much stronger irritant and usually has a much quicker response. The newer drugs that I alluded to, I don't use them very much, mainly because I'm comfortable with the old style drugs. When I have used them, I have to use them in my older individuals because of the black box warnings. We tend not to use them in the younger girls. And when I have used them, I've not been particularly impressed with their activity. I'm sure there are different strokes out there for different folks, and they may be perfectly fine drugs to use and be effective. So I think these are all options that you can certainly try with the help of your physician. But beyond the milk of mag and the senna and the suppositories, that's pretty much the gamut of the good pushers.
Great, thank you. Well, I'll speak from personal experience that I know after getting the advice from you to do a little cocktail between Miralax and milk of magnesia, we have struck a great balance for Katie. So thank you. That made a huge difference. So I love when you talk about softeners and pushers. So thanks. Okay. Is there any harmful side effect? Is there anything harmful about using a glycerin suppository daily, long-term, if needed?
The answer goes back to, again, my previous answers. We look for balance in terms of need for a medication and quality of life and avoidance of complications. So in practice, no, there is no problem using glycerin on a daily basis if you need to. There's no problem using bisacodyl on a daily basis if you need to. And there's no problem using an enema on a daily basis if you need to, because using these drugs to establish good bowel health is much better than coming in with a large impaction or a volvulus.
Okay. Thank you. This is like GI speed dating, and I'm sorry that you're getting these questions. You're doing a great job just going from one topic to the next. I've got a couple questions about C Diff. Can you talk about what that is? Question is, for a parent, it seems like antibiotics and C Diff seem to go hand in hand every time, and how to deal with this situation, or is there any ideas that you have to help?
C. difficile is a difficult bug in the gastrointestinal tract because it is considered a pathogen, which means if you have diarrhea, if you have bloody diarrhea, if you have bloody ulcers in your intestinal tract, we have to treat with antibiotics, specific ones, and the treatment period tends to be prolonged. And not infrequently, the C. difficile will recur. And so the more antibiotic you use, the more difficult the situation becomes. We know that C. difficile can be caused by antibiotic use in general, and not any specific, but all antibiotics can result in C. difficile. In some instances, when you get C. difficile, you may be on and off special antibiotics as long as a year. In some instances, we try to avoid the use of persistent antibiotics to treat C. difficile in the hopes that it will go away by itself, and sometimes it does. What you need to know is that the C. difficile is probably in our intestinal tract all along. It's that microbiome picture that I showed. There are many species of Clostridia, or the C part of the Clostridium difficile bug. There are many genuses and species of Clostridia that reside in the gastrointestinal tract, and many of them are actually good bugs, as opposed to C. diff, which is one of the bad ones. So anything that upsets the apple cart in the gastrointestinal tract has the potential for allowing or permitting C. diff to explode and produce symptoms. There are not a lot of good choices on how to deal with this particular bug, besides A, letting it go away by itself, B, continuing intermittent treatments with the drugs that we use specifically, and there are step-up drugs that we will move to in the context of repeated C. difficile infections. Certainly C would be to avoid the use of antibiotics unless you know that your daughter has a bacterial infection, as opposed to always using antibiotics for simple viral infections. And again, it's a balance. And then D, there is a drug out there which is called Cholestaramine. It's used to treat people who, it can be used to treat people who have high cholesterol. It is this gritty resin powder that tastes awful, but a lot of times we try mixing it in stuff like applesauce. For my girls who have larger button sizes, you can put it straight down the G button, but it tends to adsorb the toxin that is produced by the C. difficile bacteria. And so in rare settings, if I'm lucky, I will use this particular drug in my girls if I can get it down. But otherwise, there are no magic bullets for the management of C. diff, particularly when it recurs repeatedly, and it can be an ongoing problem. It does, in general, usually go away eventually, but sometimes we pull our hair.
Okay, thank you. I know it's a painful thing to work through at many levels. Thank you for giving it such a solid answer. We have a question about gas bloating, and once the bloating kind of moves down into the bowel tract, particularly in the large bowel, do you have any techniques that you can revisit about ways of helping rid of that discomfort once the air bloating moves down into the...
Yeah, once the air gets down into the small bowel, it fundamentally has to pass out the rectum. You theoretically could use some Cymethicone. There's another product out there called Beano. Some people like to try Beano for gas. As always, keeping the girls up, walking, and mobile is helpful. Trying to avoid the stressful situations that lead to anxiety and repeated air swallowing might be a useful intervention. At times when the air swallowing and the gas bloating becomes significant enough, I will try my antibiotics, metronidazole or clindamycin, usually more metronidazole than clindamycin because, again, clindamycin, we worry about the C. difficile. But beyond that, there are not good options to help get rid of gas beyond letting it pass on its own.
Okay. What do you consider a healthy amount of time for a girl to sit on a toilet? Because I think sometimes gravity can help, get things moving and pass. And I know parents have said to me that they might let their girls sit there for 30, 45 minutes. Is that okay? Is that healthy?
I think the toiletry issues are a personal choice. I think for some girls, they're as happy as a clam to sit there, and if it results in a bowel movement, I think that's fine. I think for some girls, they will become very agitated for anything longer than 5 minutes. And so I think it's an individual choice in terms of what works for your daughters. Sometimes if we use medications consistently, you can get an idea about the time frame that these drugs may have an effect. And in some instances, you can use your medications to help with time training so that if you do sit your daughters on the toilet, they become accustomed to knowing what's expected of them and actually do have a bowel movement within a reasonable period of time. But again, I think that's a personal choice depending on your daughter and her reaction to what you would like to have happen within the toiletry and the bowel training types of activities.
Okay, thank you. I know a lot of families have had great success with time training, both for urination and defecation. So I love your approach to just do what works for your family, what seems to work for your child, and be okay if it doesn't work, but don't be afraid to give it a try. And but mechanically, as far as bowel, muscle, all of those things, it's okay to do prolonged sitting.
Correct.
Yeah. Okay, great. I think that answers the question that was asked. Okay, moving on. For our last few minutes, I have a couple questions about research. One parent asked if you have a place to direct families where they can find studies on research that have been done on the role in the relationship of food that can help the brain and other organs that are in distress. I love to see that there is research going on MECP2 in the enteric nervous system, different from the brain, and those are all great. Is there a place where families can find more information? We hear a lot of it in the field of autism, the link between brain-gut, food choices, gluten-free, casein-free diets.
Well, sad to say, neither I nor anybody else has actually put out any kind of consistent literature. I think it will be very hard to find something specific for Rett syndrome as opposed to the autism folks. I think that is because we have universally believed that a well-balanced diet, as you would feed any healthy child, including your daughters, is an appropriate choice. I am not opposed to specialty diets like the gluten-free diet or the gluten-free, lactose, dairy-free diet. But all of those specialty diets need to be done under the guidance of a dietitian because they, in fact, can be very deficient when they are not managed properly. And it never ceases to amaze me how many people get sent out there without having proper instructions about diets such as the gluten-free, dairy-free diet. Having said that, the studies that have been done in autism with specialty diets, particularly the ones with the gluten-free, dairy-free diets, in general are not well-controlled studies. They are really much more anecdotal. And so we have been extraordinarily reluctant to recommend any kind of specialty diet with any kind of food restriction unless your daughter has a specific issue, such as celiac disease. That's a whole different ballpark. And there are other specialty diets out there, like the specific carbohydrate diet, like the phenylketonuria, the PKU type diet. Those are all for kids who have very specific disorders and really, I do not think, have any place for our girls. When we see our girls being well fed with a well-balanced diet that contains a broad mix of macronutrients, including carbohydrate and fat and protein and vitamins and minerals, these girls are my healthy girls. And so I'm not big on finding any kind of specialty diet unless your daughter has a specific need. And I think if you really want advice, then your pediatricians can refer you to a nutritionist or a dietitian in your local area and let them guide you.
Sorry. Okay. Thank you, Dr. Motil. I've heard you so many times in the past talk about the benefits of just getting out in the sun, to getting some good old natural vitamin D to help with calcium absorption. And I think that fits nicely with the idea of trying a healthy diet. Can you talk about that a little bit?
Well, one of the big issues when I meet with my families, y'all tell me your daughters don't like milk. And for me, it raises the hair on my head because we know that the critical window for bone mineral deposition is that window before the pubertal growth spurt. So one of my proverbial records is please encourage your daughters to either A, drink sufficient milk, B, eat sufficient yogurt, C, eat sufficient cheese, D, eat sufficient cottage cheese, so that they, A, meet their calcium requirements, which do indeed vary with age, and number two, milk in the United States is fortified with vitamin D, so milk is a very good source of vitamin D. We know that 25% of our girls do not consume adequate milk and dairy products to meet their calcium needs. We know that 20% of our girls do not have adequate vitamin D in their diets because their blood levels are low. So you have several ways of making that happen. One is to be sure you drink enough milk. That's a simple way for me to count calcium and vitamin D. And then if you need to, we can always use some calcium supplements, which we prefer actually come from food, which is milk and dairy. But if we have to, we will use calcium supplements. And oftentimes I am recommending a vitamin and mineral supplement simply because we know our girls don't go outside in the sun a lot. Many of them don't like it. Many of them will burn too quickly, and you certainly have to use the protective skin creams from sunburn. And so the net effect is you're defeating the purpose of the sun rays hitting your skin and providing vitamin D. So ultimately, and I should parenthetically add, we know that at least from our natural history data, 30% of our girls, by the time they're into their 20s and 30s, tend to have fractures. And I do not know all the reasons why the girls have fractures, but I do know if you don't have sufficient calcium in your diet and you don't have sufficient vitamin D in your diet, you're looking for trouble. So one of my main points for education is milk and dairy in the diet is important. If you can't get it that way, try soy. We are less enthused about things like almond milk. We prefer no coconut milk. We think that specific brands of almond and soy are better than others because they're better fortified with calcium. Your dietitians can help you with this. But very clearly, good milk and dairy consumption and probably a vitamin supplement will particularly help in the early window, good bone mineral deposition and bone formation.
Great. Thank you. We have one last question, and I think this is a really good one and a good one to close on because we are at our 90-minute mark. The growth charts that were published out of the natural history study data, what do you think of them, and how do you think families and physicians should be using those growth charts in their management of growth?
I think the new growth charts that we have established can be very helpful to reassure families that their daughters are growing appropriately for Rett syndrome. We know the girls genetically are shorter, and as a consequence, we know the girls will have lower weights. In the original data set, we said that there was no difference in the in the BMI, the body mass index scale, between unaffected girls and our girls with Rett syndrome. If you look closely at that, however, there is a subtle difference. The BMI does tend to be lower on the new growth charts for Rett syndrome compared with the standard NCHS growth charts. Now, there are some holes with the use of our Rett growth charts. We know, for example, the data that we used in comprising those growth charts does in fact contain girls who were undernourished. It was an all-comer growth chart. We know that when we have buttons in the girls who need them, we change their growth curves. So the growth curves that are newly established for Rett syndrome may not be absolutely correct either. I always tell families I'm old, so I am used to the NCHS growth charts, and my eye automatically adjusts to what I expect to see for my girls. And I'm quite used to using the NCHS BMI chart because, as I've alluded to on the slides, anytime I see a girl that's beginning to fall below that 5th percentile on that BMI chart, we begin to up the ante and figure out what are we going to do differently, because all of my parents say, I don't want a button. So for me, just the regular BMI chart, which is my gold standard, the NCHS BMI chart, that chart for me is just the most valuable of all of the charts to use because it tells me what I have to do when I see your daughters. So on that note, I think we're going to have to close because I'm being summoned to see some of my girls.
Was I on mute? Can you hear me? Okay, everyone, I think I was on mute, but if you're still with us, thanks, Dr. Motil. We appreciate it. Now you have to get back to clinic. We will get the recording out to everybody. We will get those questions submitted, answered, and posted to our website. And we hope that you join us for our next RettEd webcast on May 8th, titled IEP Strategies for Success, with our guest speaker, Dr. Val Owen. Thank you very much. This concludes today's webinar, and we appreciate your time. Thank you.